for blocking the N-type calcium channels. So all my colleagues, you know that in the kidney and the afferent and efferent arterioles, we have three channels, the L, the N, and the T. Amlodipine blocks the L channel, and cilnidipine blocks the L and the N channel, and azilnidipine blocks the L and the T channel. Now, what I realized in day-to-day practice of hypertension was blocking the L and the N was better because it dilated both the afferent and the efferent arterioles and did not allow a gradient which would be responsible for proteinuria and podocyte injuries. So these are the glomerular pressure and the gradients which are produced. So this is the pharmacotherapy on how norepinephrine will vasoconstrict, produce increase in the heart rate and cardiac contraction, and produce kidney hypoxia with renal blood flow which is decreased. And hence cilnidipine will block these L channels, and hence the decrease in the norepinephrine. In fact, in my mind, when I see my patient and I think about N channels and how to block them, because to me, N also means norepinephrine. So norepinephrine, which produces vasoconstriction, tachycardia, hypoxia to the kidneys, afferent constriction of the vessel in the kidneys. This is, to me, when I look at a patient of hypertension, is how to block his N channels. And especially younger people with hypertension who have tachycardia, who are already nervous, who are smoking, who are obese. I think of adrenaline and sympathetic overdrive and how to block their norepinephrine. And then I think that cilnidipine is one drug which, if I block his N channel, I'll be able to stop leaking his norepinephrine and sympathetic overdrive, and that might help him to control his blood pressure. So these are, cilnidipine actually was approved in 1995, and as Samir said, it was introduced in India close to 2009, 2010. I started using it. Over the last 10 to 12 years, we had a great experience, though in between we experimented with other third and fourth generation calcium channel blockers, but somehow I believe that cilnidipine is a good product. So these are all the trials. The CLEAR study and the SEA-ATTEND study, the famous Carter study on renal protection with cilnidipine, and the SEA-ATTEND study in the post-stroke patient with cilnidipine. And these are the other studies. In 2021, we had the HOPE combo survey on BP variability on ambulatory blood pressure and how it helps to control the BP variability. So mode of action, as I already told you, of cilnidipine is to block the N type of channels, and this suppresses the release of norepinephrine. Now, release of norepinephrine will not allow stimulation of the beta receptors in the heart, and therefore it doesn't increase the heart rate and the cardiac contractility, and therefore it is cardioprotective. It also does not stimulate the alpha and the beta receptors in the kidney, and therefore it increases the renal blood flow and it decreases the glomerular capillary pressures. It does not stimulate the alpha receptor, and therefore it dilates both the afferent and the efferent arterioles, and therefore decreases the capillary glomerular pressure. It also reduces RAS and overactivity of the RAS with angiotensin 2, and hence it reduces the podocyte injury, which is on the epithelium of the glomerular capillaries. So it is renoprotective. It does not stimulate the alpha receptor. Therefore, it's also a venodilator. So amlodipine is only an arterial dilator, and hence it leaks interstitial fluid and causing pedal edema. But this both dilates the arteries, and also it's a venodilator. Therefore, the chances of pedal edema reduces. And then it has other benefits on neuroprotection and improves the BP regulatory mechanism, activates, and therefore useful also in diabetes, and also improves the leptin sensitivity. So while cilnidipine is a calcium channel blocker of for us in essential hypertension, you can ponder over it, you can think over it, you can sleep over it, and then decide whether this will be good for your patients in terms of suppressing his reflex tachycardia, sympathetic overactivity, pedal edema, and protect his kidneys and end organ damage. So this was a study in the American Heart Association on comparing amlodipine and cilnidipine on cardiac sympathetic overactivity. And as we already said, that amlodipine actually increases the sympathetic overactivity. And that is how the tachycardia with amlodipine. The LN type calcium channel blocker, cilnidipine on sympathetic hyperactivity. This is the Achieve-1 trial. And this becomes important for morning hypertension because most of the myocardial infarction and stroke happens in the morning. And that's because of the sympathetic overactivity in the morning. So morning surge of blood pressure, as we all know, may be responsible for these ischemic events, both on the brain and the heart. Cilnidipine lowers BP as good as amlodipine. Cardiac sympathetic activity, this we already discussed. I won't go into the details of this. And we know the beneficial effects of cilnidipine is on morning hypertension and white coat effect in patients with essential hypertension. This was also the beneficial effects on few patients on essential hypertension and morning hypertension with 10 to 20 milligram of cilnidipine. So it effectively, in short, controls early morning hypertension. It also produces less BP variability. In my day-to-day practice as a group, we realize that amlodipine causes a lot of BP variability. So this is another important point because if I give a calcium channel blocker, I want it to be without side effect, and cilnidipine fills the gap in our practice. So it has multiple renal protection. We already said that it restores the podocyte and it dilates the afferent and the efferent arterioles. It inhibits the oxidative stress. It decreases the urinary albumin excretion and it inhibits the renal RAS system. In fact, one of our patients with resistant hypertension who was on amlodipine, we added a ARB, could not control. I actually landed using Vimeda, a combination of sacubitril with valsartan, and we also added a cilnidipine. I know that ARNI is not the drug of choice for resistant hypertension, but yes, we used in that particular patient, but slowly we could taper off the RNE and then cilnidipine 20 milligram BID took over. This patient also had developed a CKD and was on dialysis. So cilnidipine is a protective action on the podocytes, as we said, and these are the protective effects of cilnidipine suppressing the podocyte damage, and therefore, because there is less injury on the epithelium of the glomerular capillaries where the podocytes are, it will decrease the proteinuria, particularly in patients with CKD. So amlodipine works only on the L-type calcium channel blockers, thus only the afferent arterioles are dilated, the efferent arterioles are not dilated, and this leads to a gradient, as I told you, between the afferent and the efferent arterioles of the kidney, and therefore increases the glomerular pressure, and therefore the increase of the urinary albumin creatinine ratio, the UACR, by almost 14%. This was documented on 250 patients in the Carter study. Cilnidipine in hypertensive CKD patients. This was another study on how it reduces low-grade albuminuria in hypertensive CKD patient. So initially, this particular drug was used only by the nephrologist, not by the cardiologist. It's only in the last 5 years that we cardiologists took over because we realized that, and especially me, because I work a lot on advanced heart failure. So large number of my hypertensive patients in advanced heart failure also develop CKD. And hence we started using cilnidipine to also protect kidneys in advanced heart failure patients with resistant hypertension. So this is change of the glomerular hemodynamics in patients with advanced CKD. after cilnidipine therapy. It improves glomerular hypertension without worsening of the total renal function. This is a comparison of nifedipine with amlodipine with cilnidipine. I think we have covered up just a few points I would like to talk about is the pedal edema. Amlodipine, 25% of patients. Cilnidipine, only 2.5% of patients will complain of pedal edema. Heart rate with amlodipine goes to 80, 90. Heart rate with cilnidipine is actually decreased. So it becomes like 55, 60, 65. And that's good because it is suppressing the sympathetic overactivity. Proteinuria is increased with amlodipine because of the gradient in the afferent and the efferent, and it produces podocyte injury and hence microalbuminuria, whereas cilnidipine actually decreases the proteinuria. So this is sympathetic overactivity with cilnidipine blocking the N channel and therefore decrease in the noradrenaline release, whereas other calcium channel blockers actually increase the release of noradrenaline and therefore increase the heart rate, the LV and diastolic pressure, the stroke work index, and the RA pressure and the LV and diastolic pressures. So these effects of cilnidipine are new features not known to the conventional L type of channel blockers. And so it significantly reduces heart rate, as I told you, and the urinary albumin creatinine ratio, whereas amlodipine increases both the heart rate and the UACR. Cilnidipine is not associated with reflex tachycardia, unlike amlodipine. Also, as I told you, cilnidipine is associated with lower incidence of pedal edema compared to amlodipine. And this is because amlodipine causes an arterial dilatation, whereas cilnidipine also dilates the veins. So there is a backflow. So when there is the veins take over because of the venodilatation which happens.